in Africa in conjunction with Project Echo of New Mexico. These sessions are held weekly on Wednesday at 4:30, not 5:30, as advertised in part of the program this week. I hope that has not been confusing. And please, the chat is open for your questions, which you are very welcome to post. This week, our PAT session is devoted to cirrhosis, and it's a great pleasure to introduce Professor Massimo Pinzani to our GECO session this afternoon. Emeritus Professor of Medicine at UCL in London. He chaired the Sherlock Chair of Hepatology at UCL between the periods of 2012 and 2023, having retired from there earlier this year. He's devoted most of his career to the cellular and molecular mechanisms of liver fibrosis, and has served on the governing boards of major scientific and international organizations in hepatology and GI. He's also a member of the governing board of EASL. I met Massimo approximately 20 years ago when he came to South Africa with Peter Ferenczi as part of an EASL delegation. And we struck up a friendship which has endured since that time. He's been an active supporter of the foundation and GASA in advancing hepatology through EASL, and has taken part in two major trips, one as part of a fetch drift to Professor Mike Q, which we had in 2016 in Pretoria during the SAGES meeting, and also was part of the postgraduate EASL program in Addis Ababa in Ethiopia of the same year. On a personal note, my wife Maro and I have spent wonderful times with him and Lona, his Danish wife, here in South Africa and also in London, in Florence, and also in Denmark. Last year at the ASLD meeting in Washington, DC, I was in the audience when he gave a lecture as part of the postgraduate course on reversing cirrhosis to non-cirrhosis, and I was spellbound, as were many others. So I'm very grateful to Massimo for taking the time to deliver a lecture entitled Reversibility of Cirrhosis, Reality or Myth. And I also want to thank him for years of wonderful friendship and for all his efforts in rolling out hepatology in sub-Saharan Africa. Over to you, Massimo.
Thank you, Chris. It's really a pleasure to give this talk, and I'm sorry if there will be some background noise because I am just a second. Sorry. Just a second. Luna. I'm very sorry. Okay, so I'm very happy to give this talk, and let's proceed. So this slide is my disclosures, and first of all, I would like to introduce the concept of stratification of cirrhosis that, as indicated in the title, desperately seek for innovation. First of all, the term cirrhosis does not recapitulate anymore the clinical feature of advanced chronic liver disease, which is another possibility of calling cirrhosis in a milder way. And because also the term cirrhosis does not allow flexibility in terms of regression or resolution, especially in view of possible the existing and possible future treatments. Also, it is increasingly clear that different chronic liver disease, different etiology lead to different type of cirrhosis. So there is not just one type of cirrhosis. And also it's very important that we are kind of a bit dogmatic in classifying advanced liver disease just on fibrosis. There are many other phenomena and pathophysiological pathway which are activated and make altogether what we see in clinics. And finally, the new etiological treatment, particularly for example, the introduction of effective antiviral for hepatitis C, have opened important perspectives in terms of disease regression or stabilization. And I mean, overall, what I'm going to talk today is what we can consider reversible and what is not reversible. So just to set a base of our expectation for the futures. So, let's frame what we consider advanced chronic liver disease and cirrhosis. And basically, the way we classify cirrhosis and we follow up our patient is mostly observational. So based on the clinical data, a patient can be classified as cirrhosis stage 1 or stage 2 based on the absence of varices and ascites. In the first case, the presence of varices by endoscopy, but no ascites in the second case. This is called by convention compensated cirrhosis. And then at some point, in general, after many years of follow-up, the patient developed a decompensating event. And then he is classified as stage 3, stage 4, and stage 5. In general, the first episode is bleeding, but could be ascites. Stage 4 is a new episode of decompensation over a history of decompensation, and so on. And basically, this is called decompensated cirrhosis. And any of this stage can lead to patient death or the need of transplantation. And in general, with an increasing frequency of sepsis episode and renal failure. So basically, in terms of what is on the background of these stages is basically portal hypertension. And in general, a patient is in the compensated stage if the HVPG, the hepatic venous pressure gradient, is between 5 and 12 millimeter of mercury. In general, I'm talking about as a dogmatic convention, the patient is in the compensated stage when the HVPG is superior or equal to 12 millimeter of mercury. So as you can see, we have basically the way we classify cirrhosis is basically the day after. So the day after a clinical manifestation, we change the stage of the patient. Hepatocellular carcinoma is an occurrence that may happen, anytime in cirrhotic patient from even in the compensated stage. In terms of diagnostic resources, considering these stages, basically going from stage 1 to stage 2 may need many years, and we have very limited diagnostic tools to follow up when the patient is going to progress from stage 1 to stage 2. And finally, we cannot really predict easily when the patient will have the first decompensating event. So this is an area of major diagnostic need where we don't have many diagnostic tools, if we exclude portal pressure, which is also not very precise at the moment. And then on the other hand, when the patient is decompensated, the progression for stage 3, 4, and 5 to death or need of transplantation with a high MEL score may occur in few months. So this part does not require a major diagnostic effort and this should be concentrated into the stage of compensated cirrhosis. So in summary, what I will talk today is, first of all, to define the biology of cirrhosis, considering that there are different types of cirrhosis, define the clinical stage of cirrhosis, define the relative endpoint of treatment, and finally, this is the question that Chris asked me to answer, is it possible to reverse cirrhosis to non-cirrhosis? So let's go with the first point. So as you are aware, there are many etiology, many causes of liver fibrosis, different chronic liver disease, as indicated in this slide. And the question here is is there one or many type of fibrosis? And this slide is from a review that I published last year together with Scott Friedman, and basically shows schematically the normal hepatic lobule, and then the three major type of fibrosis. The first one, as shown here, is the so-called post-necrotic fibrosis, which is typical of chronic viral hepatitis, also autoimmune hepatitis, where fibrosis develop with an enlargement of portal tracts, but also with a portal-to-portal direction. But very early, cirrhosis develop between the portal tract and the central lobular vein. Port is called portocentral, and this is associated with arterialization of the sinusoids and extensive phenomenon of angiogenesis. The other type, which is very much in fashion now, is the pericentral fibrosis, typical of alcoholic and non-alcoholic steatohepatitis. In this case, fibrosis starts from the central lobular vein and then develop through the sinusoids, and in the end occupy all the lobule, and eventually result in a cirrhotic picture. But as you understand, the origin of fibrosis is basically very different from the one typical of chronic viral hepatitis. And finally, so-called biliary fibrosis is characterized by bile duct damage in the portal tract. So fibrosis starts with an enlargement of portal tract and a development which is for a long time portal to portal. So in this case, the central lobular vein is not involved unless you have then extensive fibrosis in a very late stage. And so this leads to, this is associated with also a different predominant mechanism. And as I will show later, also with the different consequences in terms of the proper feature of tissue fibrosis. Just to give you an example of the consequences, this is a paper published at the Royal Free in 2012, where basically explanted liver from patient undergoing transplantation with different etiology. You see here alcoholic liver disease, PBC, PSC, autoimmune, and viral hepatitis, where the amount of fibrosis was quantified using the collagen proportional area, which is a morphometric computerized method, where basically you can see here fibrosis is the red tracing on a black background. So you can quantify how much red is on the black background. And if you look at the amount of collagen in this explanted liver, and it's important to stress that all these patients underwent transplantation with a similar MELD score, so they didn't have major clinical differences. The amount of collagen of fibrosis that you have in alcoholic liver disease is basically double compared to the one that you see in viral hepatitis. And this is the consequence of the fact that before you develop cirrhosis in alcoholic and also non-alcoholic steatohepatitis, you have a full capillarization of sinusoid, panlobular capillarization of sinusoids, whereas in chronic viral hepatitis, you have shunting of fibrosis from bridging of fibrosis from the portal tract to the central vein very early, with saving area of the lobule which are not fibrotic, but at the same time having important consequences because early development of portal hypertension for early involvement of the central lobular vein. So do different type of cirrhosis have different biology? So there are several points to consider. The first is the matrisome. I will introduce you to this concept, which is the biochemical composition of the extracellular matrix in diseased liver compared to normal liver. Also, a few words about predisposition to hepatocellular carcinoma, which is not the same in all chronic liver disease. The development of portal hypertension, and the reversibility of tissue fibrosis in cirrhotic liver, rather than discussing the reversibility of cirrhosis. So the matrisome. So we have learned about the matrisome by developing a decellularized human liver. This is what we have done in the past 10 years in my lab in London. So we were using a donor healthy human liver, which was not suitable for transplantation, usually because of prolonged excessive ischemia time. So all the cells are removed from the liver tissue, and what is resulting is a scaffold. So it's the extracellular matrix, which also conserve the vascular tree, as you can see here. And basically, compared to the native organ, the scaffold include all the components of the extracellular matrix, as shown here, like collagen 1, 3, 4, fibronectin, laminin, with the same spatial architectural distribution of the native organ. And if you look at scanning electron microscopy, this is the cellularized human liver. This is a portal tract. This is the liver lobule. And here you have higher magnification in the liver lobule. Each one of these space include one hepatocyte. And this is a single hepatocellular space. So this is the first time that it has been shown that the extracellular matrix make niche for including a single hepatocyte. And so this is not just a virtual space, it's a space occupied by extracellular matrix. We have been able also to make the cellularized cirrhotic liver from the explant. And the same in this case, the ECM is distributed as it was in the cirrhotic liver. And this is the scanning electron microscopy. You see, this is a cirrhotic nodule, and these are capillarized sinusoid. And this is the space for a single hepatocyte in cirrhotic liver, which is, as you can see, is very different from the space in normal liver. Basically, it is like a concrete box compared to this very delicate structure of normal liver. So basically, if you do proteomic analysis, extensive proteomic analysis, we study the biochemical composition of the matrizome, and the matrizome has different components. First of all, the core matrizome genes, which are basically those coding for the extracellular matrix component, collagens and non-collagenic proteins. Then there are matrizome-associated genes, which are basically proteins which usually are affiliated to the extracellular matrix, although they cannot be considered extracellular matrix properly. Then there are ECM affiliated protein, and then there are regulators, basically all the enzymes which are important for cross-linking, but also for degrading the extracellular matrix. And finally, there are secreted factors. So basically all the factors, cytokine, which are secreted by inflammatory cells, they don't just go around, they just stick to the extracellular matrix. So finding this protein give clues about the pathogenesis of fibrosis in different chronic liver disease. So basically our strategy has been to compare healthy human liver and cirrhotic liver of different etiology, studying the matrizome, just doing the proteomics of these proteins, but also doing the secretome and the exome by incubating, repopulating this 3D scaffold with, for example, with stellate cells. And by the interaction between stellate cell and the extracellular matrix, we can study which protein are secreted by the cell matrix interaction and which genes are expressed. In addition, by incubation with proteases as something that occurs, naturally in the remodeling of tissue, both in normal condition, but particularly in pathological condition, and doing peptidomic analysis, we have been studying matrikines, which are secreted protein derived from the extracellular matrix, as I will show you in a specific slide. So comparing the biochemistry of a cirrhotic liver with that of a human liver, we find out that we can identify unique proteins, which are called quality signatures in the cirrhotic scaffold, that have a statistically significant change compared to the healthy liver scaffold. Just to give you a summary example, if we compare a healthy liver with a cirrhotic liver due to non-alcoholic fatty liver disease and a cirrhotic liver from primary sclerosing cholangitis, there are obviously protein common, but for example, in NAFLD, we find 90 specific signatures that identified very clearly a cirrhotic liver from NAFLD and 40 in a liver derived from PSC. So these basically represent an important basis for the development of biomarkers which are specific for chronic liver disease, not generically for liver fibrosis, but also it's very important to identify target for treatment, which in the end may be very different in PSC versus NAFLD. Just a few words about matrikines. So this is the extracellular matrix. The relationship with remodeling enzymes leads to the liberation of small fragments, which are called matrikine. And we know right now about 35 different type of matrikine, which have receptor on circulating cell, particularly cell of the immune system. So the extracellular matrix can actually talk to the immune system, sometimes to help the immune system to do a good job, but sometimes these matrikine are purely distractors of the cell of the immune system. So basically they can prevent, for example, the immune system to interact with an hepatocellular carcinoma that is embedded in a fibrotic liver. And also in this case, there is a difference in the production of matrikine if we compare, for example, in this case, alcoholic liver disease with PSC. So there are specific matrikine pattern for different chronic liver disease. Okay, a few words on the predisposition to hepatocellular carcinoma. I mean, this talk is not dedicated to this. This will require a full seminar. But basically, the relation between the fibrogenic evolution of chronic liver disease and hepatocellular carcinoma is a bit like a fight between scarring, which is an important phenomenon to preserve the tissue continuity, and the strong regenerative potential of the liver. And so we have a chronic liver parenchymal damage. This leads to chronic wound healing fibrogenesis. And this is associated on the other hand with the reduced regenerative potential of hepatocytes, which in most cases are either infected with a virus or are intoxicated with alcohol, acetaldehyde, or fatty acid. And for this reason, in chronic liver disease, hepatocyte become a minor source of regeneration, and um, this lead to is called regenerative nodules. But most importantly, the hepatocyte precursor, the hepatic stem cell, become the major source of regeneration, and this leads to a strong predisposition to hepatocellular carcinoma, because la differentiation of hepatocyte precursor in a completely abnormal matrisome leads to wrong signal and favor the emergence of neoplastic clones. As you can see in this slide, different etiology leads to a different incidence of hepatocellular carcinoma, with viral, especially in, as is shown in this slide, viral hepatitis, hepatitis C and B is still the most frequent cause of hepatocellular carcinoma, followed by steatohepatitis, particularly non-alcoholic steatohepatitis, and cholestatic disease shown in this slide are those that have less incidence of hepatocellular carcinoma in follow-up, although they may have higher incidence of cholangiocarcinoma. But a recent paper by Joseph Lieuvet on Nature Review show something surprising. So if we look at the expected incidence per population of hepatocellular carcinoma in cirrhosis of any etiology, child, puke, A or B, it is confirmed that hepatitis B and C have the highest incidence, 3 to 8, 3 to 8%, 3 to 5% per year. But also, as shown here, stage 4 primary biliary cirrhosis has also a very high incidence. So it is also very surprising that alcohol has less incidence than this other etiology. NASH cirrhosis in this slide is still defined as unknown, although there is a claim that hepatocellular carcinoma may develop in non-cirrhotic liver with non-alcoholic steatohepatitis, and the incidence is reported 1 to 2% per year. Portal hypertension. So you are all aware that all the clinical manifestation, most of the clinical manifestation of cirrhosis are due to the development of portal hypertension. And this is defined by convention by measuring the hepatic venous pressure gradient. And basically when the hepatic HVPG is more than 10 millimeter of mercury, it is defined as clinically significant portal hypertension. This is where all the attention, for example, in the development of non-invasive methodology, particularly elastography, have been concentrated, because identification of clinically significant portal hypertension is when more attention should be given to the patient about complication of portal hypertension and require more urgent investigation with upper GI endoscopy. And then, when portal pressure increase, all the other possible complication due to all these pathophysiological pathway increase with gravity and leads to death of the patient. On the other hand, the standardization of this limit, like 10 millimeter of mercury or 12 millimeter of mercury, it was developed in the 90s, mostly based on hepatitis C. I mean, we need to acknowledge that what we consider a threshold of portal hypertension is very much based on hepatitis C and not on other etiology. As a matter of fact, more recently, there have been papers showing that if we look at portal pressure and HVPG relationship in NASH, in a NASH group of patients with cirrhosis compared to a control group, which is basically the usual standardized group with hepatitis C, it appears quite clear that patients with NASH cirrhosis may develop complication of portal hypertension earlier than at 10 millimeter of mercury. So it's very likely that we will need to reconsider this threshold and make a more dedicated threshold for different etiology of liver disease. Just to give you an example, and how non-invasive method can help. So if we compare viral hepatitis cirrhosis and we look at the two threshold, 10 and 12 millimeter of mercury, and we do elastography in this patient with FibroScan, we see that these limits are reached with about 18 kilopascal of liver stiffness. If we look instead to alcoholic cirrhosis, for the same threshold, the average is elastography of 30.2 or 36.6 kilopascal. So it is very clear that what we consider as a standard threshold of portal hypertension needs to be reconsidered in different etiology, possibly by combining HVPG with measurement of liver stiffness. Okay, so definition of clinical stage of cirrhosis. So as I showed you before, cirrhosis is divided in compensated and decompensated with this kind of artificial observational stages. Here there is also a stage 6 compared to what I showed before, which is a late decompensation with the refractory ascites, so a more chronic type of decompensated cirrhosis. And basically, from each one of these stages, compensated or non-decompensated, there is a progression to end-stage liver failure, need of transplantation, and the possibility of acute on chronic liver failure. There are stratification tools that I mentioned: histology, HPPG, non-invasive markers. There are also other methods for stratification, like assessment of sarcopenia and frailty, and also the well-known transplant score like MELD. And what we do not have right now is a biomarker for detecting in a cirrhotic liver increasing fibrogenesis, angiogenesis, and tissue hypoxia, increasing portal hypertension and collateral circulation, and increasing bacterial translocation, systemic inflammation, and derangement of innate immunity. So these are more or less deducible from uh, doing panel of cytokine in cirrhotic patient, but there is no a clear defined rule or algorithm that is right now validated. Important to define the relative endpoint of treatment in a cirrhotic patient. So basically, the first endpoint should be a reduction of portal hypertension that we already achieved to a certain extent with beta blockers. Also try to promote liver function and regeneration, but this is a double-edged sword because pushing on regeneration may increase neoplastic transformation. That's something that, on the other hand, we should try to prevent and reduce. So going back to the scheme, so the endpoint should be in the compensated stage, in a very early stage of cirrhosis. Try to regress cirrhosis and go, for example, from early stage F4 to a stage F3. Another important point in a compensated patient is to prevent decompensation. So make the patient indecompensable in the way that prolong his survival, and having the patient dying with a cirrhotic liver, but possibly not because of cirrhosis. On the other hand, if we go on the next compartment, we in a patient that had a recent episode of decompensation and is on treatment, for example, with beta blocker and like band ligation, or is responsive to diuretic, try to keep the patient back into a compensated stage and prevent further decompensating event. Then if we go in further advanced disease, the endpoint should be a clinical stabilization and a reduction of MELD. So having a delta MELD of 3-4 points. So let's go to the last point. Is it possible to reverse cirrhosis to non-cirrhosis? So let's use the same scheme. So if the endpoint was a regression of cirrhosis, we have a very good example from the treatment of cirrhotic patient with an oral agent against hepatitis C virus. But I'll show you in the next slide. In terms of the possibility of regression, different type of fibrosis have different potential of regression. For example, post-necrotic due to hepatitis B and C have, because there is extensive neoangiogenesis, they have a limited or a reduced potential of reversibility. On the other hand, pericellular fibrosis like in NASH and ASH, where there is extensive capillarization of the sinusoid, but there is reduced angiogenesis, have more possibility of reversibility. Obviously, the liver fibrosis, which is almost fully reversible, is, for example, the one that follow chronic heart failure, if the cardiac situation is resolved or improved. So in terms of what is reversible or not reversible, these are a picture of serious red. In red is indicated the amount of fibrosis, the distribution of fibrosis. So if we look at fibrosis that is inside the cirrhotic nodule, which is mostly capillarization of sinusoid, this is actually fully reversible. But if we look at the fibrotic septa that I show here in yellow, these are the reversibility here is very limited because there is a extensive collagen cross-linking. There is extensive elastin deposition. So basically, this fibrotic tissue is more like a tendon rather than a liver. There is also downregulation of matrix metalloproteases. Also, very importantly, this fibrosis is acellular, so there are no cells, and so this, is why I say that it looks more like a tendon than a tissue. So in this case, reversibility is very limited or no or zero. So trying to reduce fibrosis in cirrhosis is probably a better statement rather than saying to reverse cirrhosis. So the example we have is the etiological treatment, the antivirals, alcohol abstinence, and bariatric. All three are successful in removing the cause of chronic hepatocellular damage. There is not yet an antifibrotic, but just I will tell you what we should expect from an antifibrotic. And finally, cell therapy. So starting with the antivirals. So here we know that the first treatment with oral antiviral for hepatitis C was reserved to patients with cirrhosis, and overall it was an excellent idea. And in this case, as we said before, the endpoint should be regression of cirrhosis or prevention of decompensation. So considering patient obtaining a sustained viral response with oral antivirals, what we have learned from many of these clinical trials is that basically patient in stage 1, so they had no viruses and they have um, no viruses and no ascites. In this case, it has been shown that the treatment with successful treatment with antivirals reduce the extent of the compensation, but increase survival only and increase survival. But in 12% of patients in stage 1, there is development of viruses within 2 years. So meaning that the fibrogenic process is not stopped by immediately by eliminating the virus. But most significantly in stage 2 cirrhosis, survival increased only if pre-treatment HVPG was less than 10-12 millimeter of mercury, and 34 of the patient develop worsening of esophageal viruses and even bleeding. So this thus confirming that SVR does not block the disease immediately, actually doesn't even stabilize the disease immediately. And this is why follow-up post-SVR requires like 3 to 5 years. Also, as shown in this other paper, here is wrongly say cirrhosis regression. I would say fibrosis regression in cirrhotic liver. It was in very high percentage in patients with HVPG less than 10 millimeter of mercury, with a liver stiffness less than 21 kilopascal, and obviously with a histological classification of cirrhosis as LENEC A and B, but not none of the patients with LENEC C, which is very advanced stage of fibrotic evolution, had regression. So I will not go into possible antifibrotic drugs because right now there is no an antifibrotic drug available for liver fibrosis. But basically, what we should expect. So in this table here on the bottom of the slide, there are the 3 only existing antifibrotic drugs which have been approved. None of this is approved for liver fibrosis. They are approved for idiopathic pulmonary fibrosis or interstitial lung disease. And this is also explained by the fact that especially IPF. It is a rapidly progressing disease, so it is considered approval of drug is very much similar to what is in general done for anti-cancer drug, but also because IPF has a very important biomarker of to check the success of the treatment, which is like measuring PO2 in the blood, saying how the lung has improved the function. So hopefully something like this will be available for the liver. But I'm telling you, with the history of research on fibrosis, 20 years ago, I would say that we will be successful in reversing fibrosis successfully, also in advanced disease. And right now, I'll be more happy to be able to halt the progression of the disease and prolong survival of the patient. So in terms of enthusiasm, we should be enthusiastic, but still, we have a lot to do. And in case we have an antifibrotic, effective antifibrotic drug, what is not reversible? The parenchymal regenerative nodules are not reversible. The vascular anastomosis, as you see here, are not reversible. The vascularized septa in cirrhotic liver are not reversible. And also, there is the formation of biliary loops in cirrhotic liver, which are basically an attempt to improve biliary delivery, and there is also in reason of ductal reaction, which is a typical regenerative phenomenon in any type of fibrosis, and these biliary loops will not be likely reversible. Okay, a few words about cell therapy. Cell therapy also will require a full seminar, but I would say 98% of what I would present is basically useless. In terms, there have been all kind of attempt like infusing hepatocyte or other parenchymal cells. So what is instead possible with cell therapy is what I will show you in the next slide, and is to obtain a return to a compensated stage in patient with the decompensated that had one episode of decompensation and now they are in treatment, and also importantly to obtain a clinical stabilization and a reduction in the MELD score. So the most promising cell therapy approach is macrophage reprogramming. So you are aware that macrophage are key cell type in the progression of fibrosis, and there is in the phase of fibrogenesis, active fibrogenesis, the macrophage involved are the so-called classically activated macrophages, or M1, and this could be actually somehow deactivated. There are several drugs that reduce activation or their recruitment. But what seems to be a more likely possibility is to make a reprogram these macrophages from M1 to M2, which is also called non-classical activated macrophages, which are macrophages which are primed for resolution of fibrosis. So basically, they have an anti-inflammatory and activity, and also are able to induce fibrolysis by expressing metalloprotease. So this work is mostly developed by the group of Stuart Forbes in Edinburgh, and is based on an early paper from 2011 in an animal model, where basically the macrophage of the mouse with advanced fibrosis were isolated, and they were reprogrammed from M1 to M2, and reinfusion of the reprogrammed macrophage leads to a reduction of fibrosis, but most importantly, by the expression of the by these macrophages of metalloproteases able to degrade the matrix in the fibrotic liver. And from this initial study, they have developed a company, and they have basically developed a method that macrophages are removed from the patient by apheresis as monocyte. They are differentiated into macrophages, and they are basically engineered to become M2 macrophages, and then they are re-administered to the patient as a treatment. And this was done for the first time in a study called Match-1, which was a safety study. They include 9 patients with compensated liver cirrhosis, male between 10 and 15, at 3 doses, 10 to the 7, 8, and 9. And endpoint were safety, delta MELD, and biomarkers. And as shown in this slide, there was, an increasing decrease in MELD score with an increase in the dose. These are 3 patients, 3 cases, but there was also very promising reduction of biomarker of fibrosis like the ELF and the ProC3, which is another marker of fibrosis. So this was very promising, and the group is now planned and is actually actively recruiting now for the Match-2 phase with autologous macrophage, where instead of 1 infusion, there is a repeated dosing, day 90, day 180, and so on. And the benefit of the treatment are evaluated up to 2 years. So this is my last slide. Which are the key messages of this talk? First of all, the biology of cirrhosis is related to the etiology of chronic liver disease and the prevalent pro-fibrogenic mechanism in these different etiologies. The biology of cirrhosis influences reversibility of tissue fibrosis and achievement of therapeutic endpoints. And cirrhosis is fully reversible only at a very early stage. And a reduction of fibrosis in a cirrhotic liver is a more realistic endpoint. And treatment efficacy needs to translate into a significant reduction of portal pressure. Thank you very much. I'm be very happy to answer your questions.
Thank you very much, Massimo. Excellent presentation. Are there any questions? Please unmute. You're welcome to post them on the chat box or unmute and ask the question yourself. So Massimo, I mean, we focus so much on collagen deposition, but your slide showing that for all the causes, major causes of cirrhosis with similar MELD scores, different amounts of collagen led to the same outcomes. So clearly, as you've shown, there are a number of other factors. How do you weight them, or is it etiologically driven? And secondly, do you think that it's important where the collagen is distributed, that will affect outcomes? In other words, whether it's collagen distributed centrally will have a different outcome than when it is deposited peripherally. Because if you compare chronic viral hepatitis B and primary biliary cirrhosis, I mean, they've got the same cirrhotic potential. We've always felt that viral hepatitis, apart from the kind of morphological cirrhotic issue, there's always that pro-oncogenic potential of viral hepatitis, and hence the hepatocellular risk. So, yeah.
Yeah, these are key points. The distribution of collagen, I mean, of fibrotic tissue, it is clearly important, but also how the pattern of development of fibrosis evolve over time is very important. But the difference between chronic viral hepatitis and alcoholic and non-alcoholic steatohepatitis is quite crucial, because in chronic viral hepatitis, there is a very early neoangiogenesis and very early predominance of the hepatic artery. So basically, the sinusoidal concentration of oxygen becomes very high quite early in the disease. So as soon as there is capillarization there is deposition of collagen around the sinusoids, the liver becomes very hungry of oxygen, and react with a very strong neoangiogenic reaction. So basically, you start to have all this attempt of connecting the portal circulation with the hepatic vein circulation, which makes a big mess and leads to very early portal hypertension. So I would say fibrogenesis in viral hepatitis is very strategically negative. You know, the way that that evolves irrespective of the total amount of collagen. So it is not only fibrosis, it's also angiogenesis, but there is for example, there is another important factor which becomes very evident in alcoholic cirrhosis, which is probably tissue edema. So everybody is surprised seeing a patient with alcoholic cirrhosis coming to the clinic with ascites, and the patient is told either you stop drinking or you die. And some patients, they actually, especially if they are not too mentally convoluted and sophisticated, they actually get very scared and they stop drinking. And then you don't see the patient coming back to you with a complication for another 8-10 years, or actually maybe never come back. So that means that there are cofactor associated to the tissue collagen, the deposition, that have different dynamics. And in the case of alcohol, there is a very early possibility of reduction. So and also the other point I made about the threshold for considering portal hypertension clinically significant, it is based on something done 30 years ago in chronic hepatitis C cirrhosis. And I think we should, revise this, but mostly we should push to have better biomarker, better imaging, and we should really invest into this. We are still quite primitive, to be honest. And I don't know if I answered.
Yeah, no, perfect. Siyanda, let me, unmute and let's hear your question. And there's a question from Dr. Machalaga. If you can also unmute and probably give it, it's quite lengthy. Siyanda?
Hi, Prof.
Hello.
Thank you for a great presentation. It's really outstanding. I just have two questions. One is in relation to, there's the concept of MELD purgatory. And it would seem to me that if the concept is to treat patients and to try and reduce fibrosis, at some point, they're going to go through that period of MELD purgatory. What improves first? Is it the fibrosis, or is it really just the MELD score that improves first in these patients?
Yeah.
And then the second question. The second question was for those patients with autoimmune hepatitis who, let's say, have F1 fibrosis. Should we then be pushing for a lower target in terms of their ALT when we're treating them?
Okay, so the first question is the effect of reducing fibrosis on the MELD. I mean, the MELD is a very effective parameter, but it's not necessarily related to fibrosis. It's related to many factors, including the synthetic function of the liver. So, I mean, in order to conclude that with an anti-fibrotic strategy, for example, this cell therapy with a macrophage reprogramming, you have an increase, an improvement of the MELD because of reduction of fibrosis. You need also to include the fact that it's not just the reduction of fibrosis, it's also the improvement in liver function that you may have by reducing fibrosis or edema or inflammation, whatever happens. So it is not really is not really straightforward. You know, it is it is also a very imprecise parameter. But on the other hand, if you need to agree in a trial for an endpoint, it is probably the best that is available right now, including and the second question was about autoimmune hepatitis stage F1.
For those patients with F1 fibrosis, if we should be pushing for more specific targets or stricter targets in terms of their disease control, suppose using ALT as a surrogate.
Okay, ALT, it is obviously not necessarily related to fibrosis. So there is always a major discrepancy between liver enzymes. So you cannot make a straight correlation between ALT or other liver enzymes and progression of fibrosis. And the example is clearly in patient, in the screening population screening of patients with suspected non-alcoholic fatty liver disease. There are lots of patients with increased ALT and they have a very mild steatosis with no fibrosis. So there is no relationship between ALT and fibrosis. So in the case of autoimmune hepatitis, I would conclude more or less the same. You need to use other method to assess fibrosis. If you don't want to do a biopsy, you should do like a elastography or whatever is available to as a surrogate measure of fibrosis.
Okay, Dr. Machalaga from Harare. So Massimo, would you like to ask your question? So Massimo, oh yeah, great. Hello, welcome.
Hi, thank you, Doctor, for a great talk. I was just interested in the patterns, the different patterns that you found in your research, and then correlated with the suggestions that there's subtle differences in the genetic makeup of the different substances that then are caused by different diseases, NASH, ASH, etc. Is it then possible to use these same livers to correlate at a genetic level, especially if they have the ischemia damage, and maybe just because locally we're not able to use ischemic livers, so we don't know what would be the capacity to do more with that?
So what is the question exactly?
So the point is that the point is that we always focus on cellular markers.
Yeah.
But you need to step back and look at kind of genetic and immune factors that may predispose to that, rather than the end result.
Yeah,
because the treatment purely on a cellular level is showing that there must be some compounding factor or some interim factors, because your study has brought out that there are different patterns to cirrhosis.
yeah, okay. Okay. Clearly the genetics of the impact of genetic on fibrosis are it's not responsible for the pattern. The pattern of development of fibrosis depends from the type of cellular damage that the damaging agent is, either viral hepatitis or alcohol or fatty acid or any other, iron, copper, whatever you want. So it depends very much on how the damage is established and what the damage cause, in the immediate microenvironment. The genetics come within each different chronic liver disease in terms of progression of the disease. For example, a patient that has, for example, PNPL3 mutation will develop faster fibrosis in any of this etiology, either hepatitis C, alcohol if he drinks in excess, or NASH if he has metabolic problem, or hemochromatosis if he has also a defective gene for hemochromatosis. So genetics is mostly based on the individual rate of progression within a different disease. But the genetic disorders that cause liver damage are the one which are well known is alpha-1 antitrypsin, hemochromatosis, Wilson disease, and a few others, you know, in pediatric age. So it's, you know, I don't know if I have been clear, but there are clearly predisposing genes to make fibrosis faster, regardless the etiology of the disease.
And then there's a question from Zama, the final question before I turn to Bilal Bobat for his for final comments. So Massimo, so clearly reversing cirrhosis, not really an issue, and it shouldn't be an issue. He's asking whether there are some markers of fibrosis. Are there any markers of fibrosis or propensity to fibrosis that you think might be feasible in predicting whether this is present or whether it will occur?
So fibrosis is the best predictor of fibrosis. No, but also, I mean, when you do a biopsy and you see fibrosis, you know, it is the best predictor of further fibrosis progression. And any surrogate has more or less the same prognostic effect. So, for example, liver stiffness over 8 kilopascal, it is clearly a sign of progression. And or ELF marker or ProC3, they are all, you know, they have more or less the same direction.
And so you're happy with non-invasive?
Well, I mean, I'm happy with non-invasive as if they are framed, you know, in the right way, in the right condition. And although in many situations you still need to have to do a biopsy with all the defect of the biopsy.
Excellent. So Bilal, any final comments from you, our hepatologist? I don't see any other hepatologists.
Hey Bilal, how are you?
Hi, how are you?
Nice to hear.
Fantastic talk. Thank you so much. And it's very special to hear this from an absolute world leader and you know absolute expert in the field. Prof, I want to thank you for all that you've done for South African hepatology and all your encouragement and guidance through the years. This is absolutely a fascinating field going forward, where we are talking about the start of cirrhosis regression. I was on a webinar recently where I brought up the topic of fibrosis regression, and one of the gastros challenged, saying no, but he's never actually heard of this as a concept. So it really is fantastic looking at the way the field has progressed and continues to do so. I think it's only appropriate that it is on the pathology session that we host this, because at the end of the day, I think tissue, it remains at the heart of the matter. And you know,
it's true.
Phrase, the tissue is the issue.
Yes.
Is certainly underlined here. Yeah, I think this is going to be a fascinating field moving forward, and especially with your various different conditions, looking at things such as biliary cirrhosis, looking at things such as, you know, pipe stem fibrosis associated with schistosomiasis even. Can be addressed more specifically for a southern African setting. And you know, I mean, I know the field is opening up in terms of anti-fibrotic agents, and it's going to be fascinating to see how it builds up. Prof, thank you.
Bilal. Thanks a lot, Bilal. Yeah.
Look, I want to thank you for the invitation. I'm very honored, and I'm very close to you. You know, I have very high esteem of all of you, and I hope, I mean, I can help more, and thank you very much.
Thanks very much, Massimo. We look forward to inviting you again, and I hope to share with you soon an Aperol Spritz, or perhaps better, a South African South African Cirrhosis. As hepatologists, we should be talking about alcohol, but it is an important part of our lives in moderation. So thank you very much, Massimo, and thank you to iEcho at the University of New Mexico, the India team. The recordings are posted on the Gastro Foundation website, so please, for those of you who missed parts of it, you can go to the website and pick it up. Thanks to the foundation, to Cheryl, to Karen Fenton, to the sponsors. And next week, our session will be devoted to IBD. Thank you all for the participation and interest. And again, thank you very much, Massimo. Grazie.
Thank you, Chris. Big hug to all of you. Bye-bye. Thank you.
Bye-bye. Bye.